Cirrhosis 3 is going to be brief, but it's entitled Fluid Infection and Bleed. From Cirrhosis 2, we finished by touching on the fact that if there is an acute decompensation, you're going to think of fluid infection bleed. In fact, anytime anyone comes into the hospital with cirrhosis, you should think fluid infection bleed. And I'm going to give you the punchline away up front. Fluid infection and bleed are the causes of acute decompensation. And so if someone comes in worse than they were yesterday, you're going to give them fluid, which means albumin. You're going to start them on antibiotics, and you're going to go broad spectrum while you pan culture. And pan culture means urine, blood, chest x-ray for pneumonia, and ascites. And bleed means CBCs in digital rectal exam looking for hemorrhage. You start them essentially on everything. Fluid infection and bleed, fluid infection bleed, fluid infection bleed, and medication noncompliance. So you're going to start them on the encephalopathic meds, lactulose, rifaximin, and zinc. In the acute setting, you're going to do all of this. Why? Because the cirrhotics have a very narrow window where you can save them. It's not like a regular healthy person who has an intact immune system. These people are very sick, and those who are decompensated, who are going to come in with problems like this, they have very limited reserve. Remember, these are patients who are already decompensated, so they have varices, ascites, or hepatic encephalopathy. If they come in worse, they're in trouble, and you have very limited window to pull them back from the brink of death. So you start them on everything, and once you figure out what the cause was, you peel back your therapies. So if someone comes in decompensated, think fluid, infection, and bleed. Fluid, infection, and bleed. We talked about the varices already in the previous video. We talked about spontaneous bacterial peritonitis as a cause of infection. We've also talked about hepatic encephalopathy on the last one. Now we're talking about fluid. And in the last video, we said there were ways of getting fluid off someone. That is large volume paracentesis, sodium and water restriction, as well as diuretics. What happens if you get that person intravascularly dehydrated? What happens? Well, I will tell you that we monitor patients based on the MELD score. When you start being a cirrhotic, the number you care about is 15, because you can be transplanted at 15. The closer you are to 40, the closer you are to death. People can live at a MELD score of greater than 40, but that usually means they're out of the transplant window. People get transplanted in the United States around 32. Very, very ill. And so if someone is walking around with a MELD of 8 and they come into the MELD of 15, something has happened. And you can use calculators to determine the MELD score. The MELD is calculated using the INR, the creatinine, and the T-billy. And so when the MELD bumps, that is the cirrhotic's way of saying, I'm ill. A cirrhotic, particularly one whose MELD score is high to begin with, may be so immunocompromised that they can't show you a fever and leukocytosis. Their blood pressures are always low. They have peripheral vasodilation, so they look like they're septic all the time. You cannot use the typical clues in everyone else to say this person is infected, this person is sick. Instead, what you have is the MELD. So if the MELD bumps, that is, the INR goes up, the creatinine goes up, or the T-billy goes up, you want to think of fluid infection and bleed. Fluid infection and bleed. And if they're encephalopathic, medication noncompliance. And your job will be to get them the medications they need. I'm making a big stink about this because I want to talk about this guy, the creatinine. What happens in the hepatorenal syndrome? Hepatorenal syndrome is essentially acute kidney injury when you have ruled out everything else. Someone comes in who is a cirrhotic and has an elevated creatinine. Fluid, infection, bleed. For fluid, you're going to give them albumin. You're going to give them an albumin challenge. You're going to try to increase the intravascular volume to reperfuse the kidneys. Infection. You're going to pan culture and broad spectrum antibiotics. When your cultures come back, you use more targeted therapy. You're also trying to rule out another cause of renal failure, so you get an ultrasound and a urinalysis. When you've done all of this and it has not shown anything, then the diagnosis of hepatorenal syndrome is made. As you can tell, you've already treated everything else. So in order to make the diagnosis of hepatorenal syndrome, it means that you have already ruled out diseases and treated different conditions that might have caused renal failure. So by the time you reach this, there's nothing else that can be done. I will tell you that in order to diagnose hepatorenal syndrome, it's the rule of twos. You have to have a doubling of the creatinine within 2 weeks or a halving of the creatinine clearance and have already ruled out everything else. Once you've ruled out everything else, including giving an albumin challenge, the only thing you have left to try is octreotide and midodrine. Generally, hepatorenal syndrome is fatal. And what I gave you is a diagnosis of hepatorenal syndrome type 1, the rule of twos, doubling of the creatinine, having the creatinine clearance in 2 weeks, and rule out everything else. That person is likely to perish. If you have ruled out everything else and you've gotten into the category of hepatorenal syndrome, but it does not specifically meet hepatorenal syndrome type 1, it is by default hepatorenal syndrome type 2. So let me say that again. Hepatorenal syndrome in general is a diagnosis of exclusion. Hepatorenal syndrome type 2 is a diagnosis of exclusion within the diagnosis of exclusion if it doesn't meet the criteria of hepatorenal syndrome type 1. That was a very long-winded way of saying if the creatinine bumps, fluid, infection, and bleed, if you've ruled out fluid, infection, and bleed, then they're in trouble. They're now hepatorenal syndrome, and you try octreotide and midodrine. Do not dialyze these patients. It does not improve outcomes. So to summarize, this was a brief lecture to really hammer home the point that if someone comes in with an acute decompensation, which is generally going to be a bump in their MELD or hepatic encephalopathy, and not the typical things that you think of a sick patient. So if they have an elevation in the creatinine, an elevation in their INR, elevation in their T-bili, or hepatic encephalopathy, you think fluid, infection, bleed, fluid, infection, bleed, fluid, infection, bleed, and medication noncompliance. You start them on everything. Give them antibiotics, give them albumin, give them lactulose, rifaximin, and zinc, and you follow the MELD score every day. Specifically, we talked about the hepatorenal syndrome, which is a diagnosis of exclusion, which is a diagnosis you do not want to give to a patient because it's often fatal. Hepatorenal syndrome has 2 types, 1 and 2. 1 is rapid, aggressive, and fatal. Type 2 is more insidious and can only be diagnosed once you've ruled out everything else, including hepatorenal syndrome type 1. Attempt to save them with octreotide and midodrine. It usually doesn't work. That is fluid, infection, and bleed.
We make these videos for free, and we need your help. Please donate, because without your donations, we can't make any more videos. Please donate.